All right, so it is Friday the 2nd. It is almost July 4th. It is almost time for explosion times. And we're going to do a review session today. And again, like I mentioned, when the people were just kind of sitting here relaxing, what I did was rather than put together a PowerPoint, I put together another Slido. I took the questions that people had sent me that they were having troubles with, turned them into unique questions, changed them around a little bit, and then made a little 25 question little Quizlet. Now I did change the Quizlet this time. I reduced the amount of time. So the last time we had 60 seconds. I reduced it to 45 seconds in order to kind of get you to speed along a little bit. So you will have a little bit less time to do this one, each question, but we're still going to review the questions. That's not going to change. So let me bring up my Slido here. Share. And get myself brought up here. And I appreciate all of you that have shown up. And if you haven't seen yet, you should have gotten an email a few minutes ago with your PEAT information. I don't know if you saw that or not, but you should have gotten an email a few minutes ago about that. Like actually the codes and everything. I found out what the problem was. They weren't activated. So I went in and activated them. All right. So I'm going to activate the quiz here. And you guys can join the quiz if you would like. Hopefully I actually like this new kind of thing I've found. It works pretty well. You guys see the Slido? Yes, I assume. Okay, there we go. Prison Mike. Oh, Prison Mike's back. There's only 3 of you, so it's not like there's going to be a ton of people in this. And if you don't want to, anyone else want to join? Not, then I'll just start it and we'll go from there.
Oh, and then you guys will just, oh, good. Cicadas in there.
There we go. I was like, wait, juniper berries. Do they have big fangs? No, all right, so we're going to start the quiz and we'll start with question 1 here. I got about 25 of them together. So again, if somebody joins in the middle, they can join. Let's start the quiz. And this is a play off of a previous one I did, right? So hopefully. All right, so we had one person pick patient feet elevated. So this one, remember I did one last week where the answer was have the patient take the blood sugar. That is always the most appropriate answer if it's there. If the patient's diabetic and hasn't eaten, the best option is to give them something to eat, right? Which one of those can we rule out? The insulin. We never give them insulin. Now the nurse can, we can say, hey nurse, can you check the patient's insulin, stuff like that. They're not dying, so there's no need to do CPR. I love that one. This is actually a question off one of the practice exams on one of the older ones. What condition do we put the patient in supine with the feet elevated?
Isn't it orthostatic hypotension?
Orthostatic hypotension. And which other one? There's one other one.
Intermediate claudication.
That's going to make it a little worse because that'll trigger it so we can tell if they have it. Intermittent collocation. I know what you're saying. Not intermediate, but I gotcha.
Oh, okay.
Shock. Right? Do you remember that mnemonic or not mnemonic? That little phrase I told you to remember about it. If they're pale, raise the tail. If they're red, raise the head. Right. So when they go into shock, they start getting pale and sweaty. At that point, lie them down, elevate their feet. If they're red, they're going into a little bit of a blood pressure or something going on with that. And that means you stand them up to lower their blood pressure. So if they're pale, raise the tail. If they're red, raise the head.
Mr. McKeever, like why you will give them a juice and you don't check their blood sugar?
Well, because that's not an option here.
Okay.
right? If the option, if there was an option here that said check their blood sugar, that would be the best option. But in this case here, the best option available is giving them sugar, right? Because the raising their legs is not going to do anything for blood sugar, right? Beating CPR, no, we're not going to give them insulin, and not probably at this point, we don't know. And again, we don't know if they are hyper or hypoglycemic at this point, but if they're hypoglycemic, they are going to pass out on us. And so it's better to give them a glass of juice, which is kind of the lesser types of sugar, right? If this said a glass of soda, that probably would be a bad idea, because that's really refined sugars, and that may not be the best option. A glass of juice has fructose, which is one step removed from sucrose, which is one step removed from glucose, which is the sugar they need anyway. And it's going to take a little bit for them to kind of break down the sugar anyway. Okay. So that would be the best option here.
Got it. Thank you.
All right. So first of all, golfer's elbow is which type of, if that's a good way of thinking of it, Eric. Cold and clammy, give them some candy. Golfer's elbow is which? Medial or lateral epicondylitis?
Medial.
Medial epicondylitis. Yeah. Right. And the way I remember, here's my way of remembering that gyra, is that I hold the tennis outside this way. So that's my lateral aspect, my tennis racket. I hold the putter on the inside of my body. So that's medial epicondylitis. That was my way of remembering those. Okay, that'll work too. I didn't think about that. Yep, T for tennis. That makes sense too. I didn't even think about that. All right, so we got a couple of these. So first of all, if you didn't know what a forearm strap is, do you really need to know that to answer this question? Let's go there. Not really. Yeah, right. You don't really need to know it. So why are we going to put it distal to the medial epicondyle of the humerus? So we're going to kind of put it just down here, just below the elbow joint. That's going to compress all of those medial muscles. Right? Whereas if I put it up here, I'm primarily going to hit most of the, I'm not going to hit the full flexor wad is basically what I'm trying to get at.
I thought proximal meant closer to the.
Yes, proximal is closer to the body.
So
You're gonna put that just distal to the medial epicondyle in order to hit all of the group. So you want to hit actually at the neuromuscular junction, right? Because if you're up here, you're more on the insertion end. Does that make sense? So if you went proximal, so here's my medial epicondyle.
Okay.
If I went proximal, I'm going to be up on the actual tendinous insertion. If I go just distal, I'm now more on the meat of the muscles. And that's what I want to put pressure on.
I see what you're saying. Okay.
Does that make sense?
Yeah, thank you.
Okay, yeah. So that means if this question was reversed and it said tennis elbow, it would be distal to the lateral epicondyle. Make sense? That's way too in-depth answer on a short thing. That's okay. That's why I did these. All right. All right, so I got everyone on this one. What do we know about PROM and AROM? Which do we have greater of? Somebody else can always move us farther than we can move ourselves. Yeah. Right. So again, this is a question that's asking best answer. So this is not, you don't have enough information to really come up with the reason why. So if I was looking at this question on the boards, because this is actually a very valid question I've seen before, I'm ruling out the one that's got hyperextension, right? Because that one's definitely out. If we don't have full extension here of the knee, we're not going to get hyperextension and active range of motion. So that one's definitely out. This one is definitely out because it adds extra flexion. So that leads me to these two answers. Well, this one down here is what?
It's the same.
It's the same. So it can't be the same. It's got to be a little bit less. And so what this is saying is, in passively, I can extend them to 10 degrees, but actively they kind of get stuck at 25. They can't extend fully by themselves. They actually have less, they have more extension lag in active motion than passive motion. And they're probably not going to flex as far either, right? Maybe whether it's due to, capsular adhesions, whether it's due to pain, whether it's due to, they just can't do it. So in a question like this, you're always going to go, okay, what answer is a little bit less than what they passively have, and pick that one. And that one, the 25 to 95 is just a little bit less. It'd been better if this question had said like 15 to 95. That would actually probably have been closer to the truth, but that's the best answer out of them. Oh, again, MS patient. And this is going to be tricky because this one uses some physics.
That was a hard one. I don't know.
That's okay. I did this one on purpose because this was actually a question that the students on the boards brought to me. All right, so we're split between the two best answers. I like that at least. Right, we can rule out the 85 and 90 degrees Fahrenheit. I don't know why I don't have Fahrenheit on there. Don't blame me. We can rule out the 85 and 90 because that's just way too warm, right? That was like my apartment for the past 2 weeks. Those are just too warm of temperatures. What's that going to cause for the MS patient?
To flare up.
Yeah, so what's the term? What's the technical term for a flare up? Starts with an E.
Episode?
No. EX. EXE. EXER. Exacerbation. Right.
EXA.
What'd you say?
That's EXA. He said EXE, right?
Oh, I can't spell. I can't spell. Sue me. Call me out on that, Jared. Good way. Way to win favor. Oh, wait, you're not a student anymore. You're fine.
Nope.
Exacerbation. You are correct. It is EXA. I can't spell today. Ignore that I just did that. But exacerbation, so that would be what you're looking for when it's talking about a flare-up, right? Because they may not say flare-up, Erica. They're probably going to say exacerbation, and that's a flare-up, just so that you can use context clues on that. All right, so the pool is the best answer, even though it's warmer than the gym. Why?
I think, is it because it's just easier on the body?
Okay,
pool?
that would be a logical answer. Good, that's not a bad reasoning. Not the right reasoning fully at this one. What do we know about water? Okay, buoyancy, good. That's one of them. That's still not it quite yet. Think about when you get in the pool and then you stand up in the air. What does the air feel like?
Cold.
Uh-huh.
Oh.
So what does the water do to your body?
Change temperature.
Yeah, it basically wicks away the body temperature, right? Because of the specific heat of water, when you get in that water, it wicks away your body temperature more than air would, right? Because think of how tightly packed the air molecules are, right? Not very tightly packed. It takes a lot to transfer that heat from your body to the air. But in the pool, right, the water is much denser, right? Because the water is denser than air. That I don't have to explain that, right? So it wicks away body temperature a lot faster, which means that's going to cause them to have less a chance of an exacerbation because it's going to be constantly, if they start heating up, just sucking that heat right out of them. Right. That's why when you get out of the pool, it feels cold in the air. Even though it could be 95 degrees in the air, all of a sudden it feels cool because your body temperature is actually lower a little bit. So that was a physics question. That was a mean one. Now, if there had been a question here that was like a clinic room at 70 degrees, that probably would have been the better answer then. Because that would have even been a cooler temperature than the 80 degrees type idea and probably would have been a little bit better of a room type thing. Safety-wise, the pool's the best option, like Erica said. Safety-wise, the pool is just the best option. So I would, if you'd have guessed because of the safety, you'd have been on the right course anyway. I had a couple of these questions come in.
Oh, these are a nightmare.
Uh-huh.
Do we want to do the opposite of the flexion pattern?
Let's give everyone a chance and then we'll
I don't-
talk. Pick one, pick one, pick one. Okay, so synergy is bad. I'm going to use that in quotes, right?
It's no good.
It's no good, right? We can use synergy to our advantage in the early stages of recovery in order to help them get out of bed and stuff like that. If we know that they've got a flexion synergy or an extension synergy, we can use that to our advantage, but we eventually want to normalize the synergy because synergy is just a regression to what type of reflexes?
Spastic?
Go even further back.
Mm,
It's a regression back to pediatric reflexes.
whoa.
Yeah. Yeah, it's a regression all the way back, or as the better term we use now instead of saying pediatric for adults is it's a regression to primitive reflexes. Right? So it's a regression to primitive reflexes. If we are positioning a patient, we want to do the opposite of whatever the synergy pattern is in order to overcome the synergy pattern. So when I think of synergy patterns and when I think deflection or extension synergy patterns, think of decorticate or decerebrate posturing, because both of those, even though they have to do more with traumatic brain injuries than they do with strokes, the positioning is the same. So if I have decorticate posturing, I'm pulling into my core. So I look like this, right? If I have decerebrate posturing, I'm going to cerebrate. I'm cerebrating. That sounds really bad. Now that I thought about it, right? My arms are going to kind of go back like this. I'm going to be internally rotated, fingers extended, stuff like that. The interesting thing about the legs, what is the interesting about the legs with both postures? Does anyone know?
It stays extended. It doesn't flex.
Yeah, it stays extended. Yeah.
Oh, that's right. Yeah, that is interesting.
Right. It is interesting, right? And that's mainly because there's all kinds of theory on that. I'm not going to, never mind, that would take way too long. Just safe to say they stay pretty extended. Now, later on in flexion synergy, the knees will pull up because ultimately flexion synergy is going to return us to fetal position, right? So if with either flexion or extension synergy, the knees, the hips are extended, there's just a change in internal external rotation. Don't really worry about that. That's not going to be that is not going to be a question on the boards. And the feet are going to be plantar flexed. So if we provide them with a washcloth in their hand, what's that actually doing?
flexing.
Yeah, so what's promoting the flexion synergy,
Yeah.
right? So it's going to cause them. Supine with the foot in 45 degrees plantar flexion, promoting the flexion synergy, right? Side lying with scapular protraction. What am I doing there again?
Promoting.
Promoting it. Yeah, so I want to do the exact opposite and kind of get them back here if I can. And does the position side lying supine really matter? Not truly. I mean, side lying's best option for a stroke patient so they don't end up with that arm kind of stuck under them. But I mean, the posture is not so much as getting them out of that posture, right? Now, if I was an extension synergy, I'd want to have a flex posture. Does that make sense?
Mhm.
Maybe a protracted shoulder, externally rotated a little bit, and then kind of in here to the chest. So I might give them something, or I might have them take their hand and put it over on the bed rail, right? Because that way that promotes that kind of flexion synergy to the reverse of the extension synergy, right? Does that make sense though? Because I had a bunch of questions on synergy patterns.
What I had to do was memorize what each flexion and extension pattern did.
Yep, that's a good way of doing it, but I'm trying to give you a cheater's way. If you're at this point, you're like, I'm not going to memorize these. It's not going to happen. It's just not sticking. What I always remembered is that flexion synergy looks like you're carrying a basket. And extension synergy looks like you're kind of doing PNF D1 extension.
The Naruto run.
The Naruto run, yes, exactly.
I thought plantar flexion was part of the extension one.
It's actually technically part of both. Technically. Again, what I was getting at is flexion will tend to trend up eventually, but initially in both the cerebral and decorticate posture, you can kind of plantar flex. Now, eventually, like I said, in a flexion synergy, it will start pulling up in. So if this gave us a timeline, it probably would have been a better question. But again, I didn't write this question. I just stole this question. I modified it a little bit enough to make sure that I didn't get caught for, what do you call it? Plagiarism. All right. You all should get this one. This should be 100% correct. I'm going to cry if you guys don't get it. Like, I'm literally going to cry. This should be a gimme. I'm hoping. Please be a gimme. Please. Yay, it was a gimme.
Yay,
Right?
we did it.
So with that one, the diastolic shouldn't really ever change, right? Diastolic's only going to change if they end up with like high blood pressure or, major changes like orthostatic hypertension or hypertension, meaning the blood pressure goes up when they stand up, which is an odd situation. Or if they end up with autonomic dysreflexia, right? Change to 20 millimeters mercury in either systolic or diastolic would be orthostatic or would be AD. So any of those, right? Our heart rate's going to go up, our rest rate's going to go up, and our systolic blood pressure is going to go up a little bit when we're exercising. It just happens, right? Body's increasing demand.
Oh, Mr. McKeever, for the oxygen, is it 95 or 90? Because
so in a healthy adult, 95% is ideal or more is greater. In order to exercise, 90% is preferable. Does that make sense? What is our cutoff? What is our cutoff that we won't exercise anymore? Under what?
85 for COPD.
For COPD, and then what about for regular people?
90, right?
I thought it was 90. No, it's lower.
80.
80.
Oh.
90. So when I say exercise, I mean any exercise, right?
Oh.
So under 90 would be bed exercises ideally, right? Under 80, they're losing 20% of their oxygen. That would be one where we're like, nope, this is a hard wave off. Let's get the nurse in here. They might need, what do they probably need at that point?
The oxygen tank.
Okay, they may need oxygen. The other
or
is
maybe the AC diaphragmatic breathing.
Okay, diaphragmatic breathing will help. Yep. Okay, good. Right, those are all treatments we can do. What's the treatment that we can't do that they probably need?
A breathing treatment?
Maybe. Okay. A little bit further, a little bit more technical, dealing with one of Jaira's constant questions about this. What's his favorite topic? Arterial blood gases.
ABGs.
How do we fix those? We give the patient blood.
Oh, I see. Yeah.
We're going to give them red blood cells, right? We're going to give them a blood count. We can't do that, right? So if they're under 80, they probably need a blood transfusion because their body's just not producing enough red blood cells. So we're going to have to probably give. Now, could all of those other treatments help? Sure, but likely it's going to raise it to like 85, maybe 87. It's not going to fix the underlying problem. They just don't have enough hemoglobin right now transporting the blood or transporting the oxygen. Does that make sense?
Mm-hmm.
So
Yes,
yeah, they'll feel better. And right, if we flood them with oxygen, their values are going to go up. But as soon as we take them off oxygen, what's going to happen?
It's going to go back down.
Right back down, yeah, right? Because the problem is not necessarily how much oxygen's in there, it's that the blood just can't transport it. Speaking of, are any of you guys feeling pressured by the 45 seconds yet?
I am.
Okay,
I
good.
am also.
Good. All right, so we're kind of split here, or we're split on the right too, at least. I appreciate that. Right? Because we can rule out breathing with accessory muscles because we're not supposed to do that with active cyclic breathing anyway, right? And then inhalation time is already the problem, right? Now, equalizing respiration rate would be ideal, and that would be moving towards the right thing, but the best answer is increasing the exhalation time.
Oh.
Because what's the problem with COPD?
Oh, they don't exhale. Go ahead.
Yeah,
Okay,
you're right.
so
Nope, you guys are going. You guys both had it. That's fine. Yeah, trapped air. That's the problem, right? I'm breathing in and the air is getting stuck in there. So by increasing my exhalation time, right? Remember when we did that with pursed lip breathing? In for 2, out for 4. Right? You remember that?
Mhm.
Yes.
So if pursed lip breathing would have been up there, that would have been the absolute best answer. But all pursed lip breathing is increasing exhalation time, right? Smell the roses, blow balloons or blow up bubbles.
Oh, no.
Did you pick the wrong answer? Very
No,
good.
I just realized it was a spin and snout.
Yep. I threw this on just for you.
I know. Oh, wait. Now.
Uh-oh.
Can I change? Oh, I
I don't
can.
know.
Oh. Wait, no. Watch, it's wrong because I changed it.
Oh, okay. So
Oh.
good. Remember, because our aunt, it's just like Erica was screaming there for a few seconds. Right? Spin and snout. Right? Now, it just happens to be that test number 1 is perfect, right? That's about as close to a perfect test as you can get. Because that means if I am positive, right, specific test that is positive, I can be pretty sure they have whatever that problem is. But this also has a really high sensitivity, right? Which means if I get a negative result, I can pretty much rule it out. This test down here, that's a crap test, right? Now this test here, what would this test be better at doing?
Identifying negatives.
Yes,
false
identifying negative. Well, just identifying negatives. That would be ruling out the condition. Now, it's still pretty good specific wise, right?
Yeah.
But this one's better specific wise. Right. So this one would be a little bit better even than this one at ruling out the condition. So maybe if you had both these tests, say you got a negative result up here, and you're like, okay, and then you got a negative result with this test, you definitely at that point can say the patient what?
Doesn't have it.
Doesn't have it. Yeah. Right. These tests down here, I mean, that's a mediocre test at best. This one is definitely garbage. That makes sense. Does everyone remember that spin and snout stuff? I hope.
So, Mr. McKeever, as long as it's above 75 and it's close to 100 on both negative and positive.
Yeah, or I mean, it just depends upon what I'm looking for. So if I've got a test that is like this, specific 0.91 and sensitive is 0.1, that's 0.10. That is still a good test, but only for checking if the patient actually has the condition. Right? It tells me nothing if I get a negative. Literally, that is literally the definition of telling me nothing. Right? So this test would be good. Like if I'm like, I am pretty confident, say this patient has plantar fasciitis, and there's a plantar fasciitis test. There isn't. I'm just using that as kind of an oddball one, right? And I'm like, I am almost confident, and I test them with this test, and I get a positive. I can be pretty darn sure they have plantar fasciitis. But if I run this test and get a negative, I'm like, well, maybe they have it, maybe they don't. I don't know. Right? It doesn't really tell me anything. So yeah, higher than 75 is ideal, right? So higher than 0.75, which is 75%. And the closer those both can get to 100, the better the test. Yep.
Okay.
And just remember, just make sure you're looking at this one saying to confirm, right? If it's confirm, you're ruling in. If it says deny, you are ruling out. That makes sense?
Yes.
So confirm is in, deny, or I know there's another term, I just can't think of it right now on what I want to say. Or just rule out, a lot of times they'll put, so. All right, see, you didn't get that bad there, Erica, don't freak out. I did this one just for you too.
Oh man.
I'm going to give you my secret to this, or at least my way of thinking of this, and see if it helps you guys.
I definitely need it. I feel like I get half of them right just for luck.
Let's say don't luck.
Yeah, really. We'll see.
All right. Okay, so here is Mr. McKeever's technique for answering these questions. First thing I do is I do the motion that I'm having the problem with. Okay, so I'm having a problem with elbow flexion. And then I think to myself, what capsule is limiting me into elbow flexion? Well, it can't be the anterior capsule. Why can't it be the anterior capsule? What's happening to the anterior capsule in this with elbow flexion? It's getting shorter. Does that make sense?
Mm-hmm.
I mean, theoretically, if it's swollen, sure, but that's not what we're talking about here. When we're talking about capsular patterns, the capsular pattern indicates a capsule is tight. Does that make sense so far?
Yes.
Okay. So if I'm limited in elbow flexion, what capsule is keeping me from flexing?
humeral.
Okay, don't even go that far. Don't even
Oh,
like, don't even use anatomical, just use anatomical positioning. So it's
Okay.
my posterior capsule,
Posterior capsule.
right?
Okay, the posterior.
Does that make sense at least?
Yeah.
Okay. So if I have a capsule on the posterior that is tight, and then I have to think, how do I stretch that capsule? So this is my process for answering these questions. I go, okay, so my posterior capsule is my tight one. I got that far at least. I've got to stretch that. If I do a posterior to anterior mode, so again, which is also known as an anterior mode, right? So if they're going to be labeled for the direction you're going, right? So this is anterior to posterior. This is posterior to anterior. This can also just be called an anterior mode, and this can just be called a posterior mode. Does that make sense at least?
Oh, I didn't know that.
Yeah.
Oh,
That's why I'm covered. That's why I figured some of you were getting these answers wrong. That's why I wanted to make sure I hit it. This is the preferred terminology now to say I am going from anterior to posterior, right? So an anterior to posterior mode is going to go this way. Does that make sense?
mhm.
You can't see what I'm doing. I forgot I don't have my studio. I'm going that way, right? I'm pushing the ulna basically backwards, right? So I'm separating that olecranon fossa almost like this. Does that make sense?
Yeah.
Right? If I go anterior to posterior or posterior to anterior, what actually is happening to that posterior capsule? It's getting what?
Longer, or was that more?
It's going to get shorter.
Short?
If I go
Oh,
from
it's going.
posterior to anterior, it's going to get shorter because I'm actually kind of doing one of these. I'm like gliding it up and bringing it closer to where it was. Technically, and here's the rule of thumb for this when you're actually in the clinic. Guess which mobes we're going to do in a clinic wise? All of them. And why is that? Because we can't agree on any of this. I'm going to be 100% honest with you guys about that. Like literally, I was on a call, like I don't know if I told you guys about this like last week, where we spent 3 hours arguing as clinicians about mobes. And I'm like, well, I do this and I do that. By the book, if I do a posterior mobe, which is an anterior to posterior,
Mhm.
right? So if I've got, let me see if I can get my little cloth here and if I can hold it while I'm doing it. Right? So if I do this way, do you see how that's stretching when I go?
Mhm.
Right? So if I go up here though, it is stretching a little bit, but it's also shortening, kind of filling in that gap. So it's not actually going to get a stretch as much as I go this way.
Okay.
Does that help?
Yeah, that helps a lot.
Right?
I guess silly of me not to realize the flexion would be stopped. Like the elbow flexion is being stopped by the posterior, like held back by the posterior capsule.
Yeah. Now,
Okay.
could it also be, could a cephalid to caudal mobe also help? Sure. Wait, which here's the problem with this. These two mobes are what?
Same.
The same.
Oh, I gotta write that down.
Think about that for just a second. Right?
Okay. Head to tail.
If I'm in anatomical position here, right? A cephalid head to caudal mobe is going that way,
Mhm.
right? Proximal to distal mobe is going same direction,
Oh man,
right?
mind blowing.
Yeah, that help anyone else? I'm glad Sukina, I appreciate you answering. That's great. That means you kind of got that theory there.
Yeah,
So-
it's just I couldn't tell which one will be from the first one and second one.
That's fine. No, I mean, that's good, right? And so
Yeah.
let's use it as, let's do a different one here real quick before we move on to the next question. Okay, capsular pattern of the shoulder. What is it? What are the 3 motions? Don't even worry about which is great. It's just what are the 3?
Abduction,
Okay.
external rotation, And there's one more.
Yep.
Internal.
Internal. Yeah. Those are my three motions of capsular patterns. Now it's external first, abduction second, internal third out of totals, right? But it's not really a big concern there, right? If you're going to get a question, it's going to say the patient's limited in external rotation or abduction. It doesn't matter. If they say external or abduction or internal, it's pretty much a capsular pattern. Pretty much for the good reason. The only time it wouldn't be if I said extension, you're like, nope, not capsular. Does that make sense?
Mm-hmm.
All right. So let's say that my problem is external rotation. So my humeral head is going from here back here.
Okay.
What capsule is stretching?
The
Interior.
Good. The anterior capsule. Right. So that's my tight capsule. Does that make sense so far?
Yes.
Oh.
Oh, did it just click?
Is that, yes, that's why I got that other question wrong.
Right. Okay. That's why I was covering this here.
Yeah.
See how I did that? It's amazing how I integrated that. Right. And so then I need to mobilize that capsule. Right. And if I anteriorly mobilize it, what am I doing to that anterior capsule? Shortening it.
So you want to do a posterior
Yep.
or anterior to posterior.
Yep.
lobe.
Or a posterior mobe.
Right. Oh
Right.
man, this is blowing my mind. This is so helpful.
So basically the rules for the joint, we always go to the opposite direction of.
Yeah, or you could go, I mean, it depends, because like if I've got a superior capsule problem, I could also go distraction. That also helps. Right. So yes, it's a fairly decent rule of thumb. How's that, Sukena? And it's
Because the PT crash, they mentioned something about that, and they said you go the opposite direction of the whatever
Yeah.
you fix in. If it's interior, you're gonna join more on the posterior part.
Yeah. Right.
Okay.
Yep.
Okay.
I mean, like I said, it's a good rule of thumb, but there's some caveats to that like, you know, if you've got something where you got some distraction can help too.
Got it. Okay.
Did that help sink that in, Erica? Because I knew that
Yeah.
was getting you. All
That
right.
helped a lot.
All right. Look what I added here right after that one. Guys are done.
Oh, I don't know for this one. It's between the two and it. This one. Okay, I gotta figure out how to silence these.
I don't care about it. They're not bothering me.
Oh man.
Okay. Abduction. Right. What's my limiting capsule?
Okay.
Oh, you
Ooh.
cannot lift up your shoulder. You cannot lift that up all the way. So
I just read that wrong.
That's okay. What's my limiting capsule?
Inferior one's limiting it.
So which way do I want to go?
So you want to go.
Superior.
Yeah.
Okay. So that's what we want, but we don't want.
Oh, wait, I think I checked the wrong answer here. That might actually be my fault.
What would not be the effective.
Yeah, I checked the wrong answer. This is partially my fault.
Yeah.
Sorry. No,
Okay.
Gyra, you went the right way.
Woo!
This was late. So superior to inferior would be a good one. Right? Oh wait, hold on. No, I did pick this right. Okay. I forgot the knot. The knot is the important part.
Oh, yeah. Okay.
Right? Superior to inferior is my
See,
ideal mobilization.
that's what happened to
Yeah.
me. I'm like,
Exactly.
ooh.
You had me question it there for a second, Gyra, so thanks. Superior to inferior is my ideal one, right? To go the opposite of the capsule that's restricted, right? Would a PA mobe still help? Probably, because my inferior capsule is going to go here, right? So my inferior capsule is going to attach at both portions, the front and the back, so it's not going to really hurt. Scapular upward rotation mode. Why is that going to help?
Because it
Because
affects.
the scapula has to upwardly rotate in order for me to
Yeah.
abduct, right?
Yeah.
So that's not going to hurt. The only one that's not going to do anything is that inferior mobe,
Ah,
right? Oh, wait.
But or the
Yeah, I did mark
Yeah.
it wrong. Now yeah, it should be this. It should be E.
Woof.
Yes. Now you got me all messed up. Oh my God. It should be this one. I'll fix that.
Okay.
Yeah. So this one's okay. This one's okay. This one is what we want, right? This one is the one we should rule out.
okay.
There we go. And my brain is, it's been a long morning. Yes, think you have fun. I have loads of fun. All right. I've got another one coming up, so that'll help a little bit. See?
Oh man.
Okay, there's two that you can rule out right away.
Yeah.
So rule those out and then pick between the last two. All right.
Yes.
There we go. Good. Mr. McKeever didn't screw that one up because he made this at like 6 o'clock this morning.
Oh my gosh.
All right. So now let me ask you something. What if it said that the anterior capsule has a ganglion cyst in it? What would that mean for joint mobilizations?
Isn't it contraindication?
There you go. Yeah, they're contraindicated then.
Ooh.
Why?
Could you rupture the
It's
cyst?
Yeah, right. Or you could just damage the cyst. It may not be like an infected cyst. It may actually be something like a nerve cyst or something like that, or a tumor, right? But the main idea is if I start mobilizing that joint, I'm going to screw that up worse. So yeah, if a cyst would be a contraindication to joint mobilizations in that joint, right? If I've got a cyst, if I'm mobilizing the wrist and my cyst is up here in my shoulder, whatever, right? But a cyst in that joint would be a contraindication.
Oh, Mr. McKeever, before we move from this one, can you explain it? Because I was thinking and I didn't get a chance to answer. There wasn't
Okay.
enough time.
All right, so here's my foot.
Yeah.
Right? So this would be my posterior capsule. This would be my anterior capsule, right? So my anterior capsule would be up here on the dorsum. This would be on the plantar surface. The foot would be on my posterior capsule, right? We got that part of it at least.
Yes.
Okay, good. So it's saying I am moving into dorsiflexion, right? So I'm pulling my toes up. What's happening to my anterior capsule when I go into dorsiflexion?
Is it stretching?
Think harder about that a second. Because part of the anterior capsule is going to be my tibialis anterior. Right? What happens with tibialis anterior when I dorsiflex?
Yes. It's shortened.
It shortens.
Yes.
Yeah, so that means my anterior capsule shortening. That means that's not really restricting me unless I've got a ganglion cyst again.
Yeah.
But this whole posterior capsule has to lengthen in order to get me into dorsiflexion. So that means my posterior capsule is my tightness. Does this look familiar to you, Erica, this question?
Okay.
Was that one of them?
Yeah, it was one of them.
Oh.
I just modified it a little bit. And that one I was asking you, which way do you mobilize?
Oh, okay.
And I just changed it to which capsule it was.
Nice.
Oh, look at this one. Let's see what we got here. All right. Wrong mouse. This is the mouse I need. All right. So now let me ask you something.
Yay.
All right. Could anterior to posterior mobs help?
Yes.
Maybe. Right. Especially for pain.
Oh, okay.
Yeah. I mean, they could help. Right. But because this is shoulder flexion, that is not a capsular pattern.
What?
Remember, a capsular pattern, external rotation,
Oh,
abduction, internal rotation.
oh
Don't get
my-
stuck. Yeah. And that just hit you, didn't it?
yeah.
Right.
If this was capsular, no, but it's not. It can't be because
It's not typically going to be. Now, does that mean that we never get a shoulder flexion that's limited because of the capsule? No. I mean, it's possible,
Mhm.
right? So that if mobilizations aren't the solution here, what are we going to do to help this? What are two techniques we're going to use? The two S's.
Strengthening and
Stretch.
Yeah, stretch and strengthen.
stretching. Yeah.
Yeah. Right. We're going to stretch stuff that's tight and strengthen the stuff that's weak. Right. Because maybe the anterior delt's the problem. It's just weak. So we're going to strengthen the anterior delt. Or maybe it's the lats that's the problem. So we're going to stretch out the lats. That adds a question here. What happens if, or why would the shoulder flexion be limited in posterior pelvic tilt? Why would shoulder flexion be limited in posterior pelvic tilt?
Isn't it the one we covered?
I know, I'm recovering it to make sure.
Is it because of Latissimus dorsi?
Good, right? Why you got the right muscle, and why?
Oh,
The fascia?
The fascia. There you go. Good. Seems
I
familiar,
remember
doesn't it,
that one.
Sukaina? Yeah.
Yeah.
That's why I wanted to bring that up. So think about this for a second. What is the origin of Latissimus dorsi?
Intertubercular of the humerus.
Okay, good. What about the insertion?
on the vertebrae somewhere.
Yeah.
Okay.
Around
Via
there.
the,
Somewhere in the
Good.
spine.
via the what?
In the T's.
Good, but via the what?
Oh, via the what?
The thoracodorsal fascia,
Oh,
right? It doesn't actually attach directly onto bone.
I didn't know that.
Yeah, it attaches to the thoracodorsal fascia. So that thoracodorsal fascia is on the back that goes down and attacks to the lumbar thoracofascia, which guess where that attachment point is?
Lumbar.
The posterior superior
Iliac.
iliac spine. Now, if I posterior pelvic tilt, what happens to that posterior iliac spine? It goes downward. That means it stretches that fascia out. Yeah, right. So now I'm like here and I'm like, I can't do anything. And then you have me anterior pelvic tilt and I'm like, oh yeah, I've got it. Right. Then we find out that, oh crap, they're limited in shoulder flexion because their back is tight.
Yeah, counter nutation. Or
Yep.
would it be counter nutation?
I mean, theoretically, that would technically be
Tilted.
nutation. Counter nutation would actually make it worse.
Okay, yeah.
Yeah, nutation is anterior.
Yep.
tilt.
Yeah.
So I think of nat. I don't know why.
But yeah, so you're on the right. The only reason I brought this up is because Sukaina and I talked about that.
That's a good one.
Oh, this looks familiar, doesn't it? Modified it slightly.
Wait, why is there a 3.3? Is that a thing? I can't remember if that's a thing. It's a thing? Okay.
Okay, so we went to the right direction at least. I appreciate that. Why did we pick the 3 or the 3.3 megahertz?
I was
Because
more
it's deep.
Yeah.
Oh, no, superficial. Sorry.
Superficial. There we go.
Yeah.
Okay, good. Right. Okay, so here's the deal about the 3 and the 3.3. It doesn't matter.
Oh, okay. Okay.
The 3 megahertz has a variance of 0.4 megahertz. So technically 3 megahertz could be 2.6, right? Or it could be 3.4. That because of the way the crystal works, right? So like a 1 megahertz could be a 0.6 or it could be a 1.4 just because the crystal's vibrating, right? It's hard to specifically say that's the only hertz that's occurring.
So a 3 is a 3 is a 3.
A 3 is a 3 is a 3. Yeah. So it doesn't really matter if it's 3 or 3.3. 3.3 does exist on like BTL machines is one of the companies that makes 3.3. And I think they did it just so they could be cool and say that they've got a different thing. Okay. So yes, shallow, superficial, right answer there. Good. So we didn't pick any of the ones. What is your key term that leads you to continuous?
Contracture.
Yes. Contracture means we need what?
To warm it up and stretch it out.
Yes. Right. So remember I did that whole, what do you call it? That little, like almost that Venn diagram I talked about where I was like, okay, so are we looking for heating or are we looking for healing? Right. So if we're looking for healing, we're looking for pulsed, looking for heating, we're looking for continuous, right? And things for heating would be contracture, tight, sore, contracture, spastic might even be technically one, or rigid, technically could be. Healing would be injury, torn, broken. Those would be pulsed. Does that make sense? Those words?
Yes.
And then we go, are we looking for deep? Or are we going superficial? Right?
Mr. McKeever,
Yep.
what about inflammation?
Okay. Inflammation, well, it depends. If it's inflammation with swelling, what do we do? Heating or pulsed? Which works better, pulsed or continuous for swelling?
I will say pulse.
Yes. Yeah. Good
Or
guess.
logic.
Yeah. Pulse would help kind of facilitate pushing that fluid back out. Right. If we heat up something that's really inflamed and really swollen, what's that actually going to do?
Make it worse.
Make it worse. Yeah. Now, if it's a chronic inflammation, I guess theoretically continuous would work, but they're not. I don't think they're going to get that totally specific with you. Right. So we figure out if we're doing heating or healing, if we're doing continuous or pulse, then we figure out, are we going deep or shallow, 1 or 3, right? And the last thing we have is our intensity. And to be 100% honest, most of the times it really doesn't matter because they're not going to get that specific in with it. But if you have a smaller area, right, you go with a smaller intensity.
And for pain, if it's out of the acute, would that be heat?
Yeah, I mean, theoretically.
Because in my mind, I think like you're trying to intercept those receptors with that continuous.
Yeah, I mean, that you could use that theory for it, sure. I'd probably use something other than ultrasound for that. I'd probably do deep tissue or a hot pack, but yeah, you could.
Okay. I think that was a PTA final question.
I mean, theoretically, yeah, because the pain would trigger the gate control or the continuous to trigger gate control. So yeah. Right. And if you have a larger area, you're going to use a larger intensity. That's kind of my theory on those.
Mm-hmm.
Now, right, that says larger. I promise I can write today. Does that help at least kind of come up with a little Venn diagram for those?
Yeah, I like the Venn diagram.
All right, got a couple more. So this actually has two parts to it that you have to think of.
Hmm. Oh, yeah.
Okay, so with the two parts you have to think of here, right? First of all, you have to think of what position do I want to put them in? And then how do I want to start? So at least the how do I want to start is right. Why would you want to start with vibration?
To help get the mucus out.
Okay, that does, yeah.
Yeah.
But why do you think you'd start with vibration first, like logically?
Age-wise, because
Yeah.
it's only 12.
Procedure.
Right now, does that mean I'm not going to do aggressive percussion? No, I probably am. But I've got to build trust with him before I start beating on him. Right? I've got to get him like, okay, get used to that. Okay, get used to my hands being on you. This is what I'm going to do. Okay, now I'm going to do, and then I might start with some light cupping, right? And then get into the kind of that aggressive percussive. So then the next question to figure out is what posture is best. Now, I didn't give you if it was an anterior or posterior upper lobe, did I?
No.
Yeah, it's not there.
Right, yeah, right? So you don't have all the information here that you would need to really decide if you wanted to start in supine or seated. But if you're working with a 12-year-old child, probably what position is going to be most comfortable for him?
Supine, so it can be relaxed.
Seated.
Seated.
Oh.
For him, not necessarily, don't even get into the how to clear it. Just again, think of what is going to be because you have a 12-year-old and the number one part of 12-year-old is safety and building trust.
Oh.
Right? Because if I break trust of that first treatment, what's going to happen?
It's gonna
They
be
won't come back.
They won't come back. Right? Or they'll request somebody else. So I've got to build a little bit of trust. So honestly, just having him sit there and go, okay, right, I'm going to work on these upper lobes. I want you to just kind of sit there and I'll start seated. Does that make sense? That's why that's the best answer here. Now, if it was superior, so what I have upper lobes, right? So if I said upper and anterior, which would be the best position?
supine.
Supine.
Right? And if I said upper and posterior, what technically would be the best position?
Leaning forward 30 degrees with a pillow underneath.
Yeah, so forward seated, right? Yeah.
Forward sitting, yeah.
Right. And that's why I didn't indicate kind of what position of seated or supine they're in. Right. I didn't even indicate if they're in Trendelenburg or not in supine. In this case, this combines, I'm looking at this going, okay, my number one thing at this point, because I have a 12-year-old, is building that rapport. Right. And building the safety and trust between me and that patient. Does that make sense for this one for you guys?
Mm-hmm.
Yes.
Yep.
Okay, good. Oh, this one ties back to one of the previous questions. I love how I forgot to capitalize the T.
Mhm.
I'm looking for Moss Def here. Okay, so what do we want to avoid first of all? We want to avoid doing what?
Flexion.
Flexion.
Flexion synergy, right? We want to avoid going into that, right? And so in this case, we go, what is the most correct answer here? Because external rotation technically would be correct, right? But let me show you something.
Oh, come on.
Right?
Come on.
That's external rotation though, isn't it?
Yes.
Right, yeah. So now if I said external rotation here, yeah. Right? But technically that's external rotation. So that would also open up and kind of get out of some of that flexion synergy too. So that's in this case, the protraction is the best answer. Because there's no way I can say a protraction actually gets me out of flexion synergy. No matter what I do, there's nothing. I know that was a technical question. I know that Erica's throwing apples at me right now. That's okay. That was one of those, oh, this is not the best answer. And I hate those questions, but I have to throw a few of them in there.
Yeah.
Okay. Does the patient even matter in this question?
No.
Okay, good. The patient is just there as a complete distractor. Because now you read that and you're thinking, well, what are the conditions of cerebral palsy? Was it spastic or is it flaccid? I mean, what's going on here? What kind of assistive devices are they using?
Yeah, I went straight into like, well, that's a crouch scissor gait. You're like,
okay, good. Patient doesn't matter. Okay, I'm gonna get stones thrown at me here.
oh, come on, what?
What's the key word there?
4 point. So they're gonna be like thinking.
Yes, the key word. So what's the key word of the question?
Cognitive work.
Cognitive.
Think about cognitive work. I thought, I was like, they don't want to think. Well, not like that, but you know what I mean? Like
you were thinking what's the easiest to teach them.
Yeah, I was thinking what was the easiest for a cognitively impaired patient.
Right. Oh. And that's the point of having the cerebral palsy. Because the cerebral palsy, you're like, oh, brain damage. Oh, they need something easy.
Easy, yeah.
Right. But what we're focusing on here is actually improving that cognitive work. Ah, right. Okay, so I don't know who picked the bottom one, but I'm going to throw stones at you.
Well, it was me, Mr. McKeever, because I thought they would be like, you have to tell them, okay, walker first, right, left. So they're going to be like using their brain.
I realize that. But why do you think I'm going to throw stones at you?
Normalized gait.
Yeah, normalized gait, but also with what?
Standard walker.
Can they do normalized gait with the standard walker?
That doesn't exist.
They don't need standard walker. Oh, man. Okay.
Right. Okay. Yeah. If I just said normalized gait, that would be the best answer. If it was just normalized gait, period, because that requires the most cognitive work, doesn't it? Think about it.
Yeah.
Heel toe, roll through. You're actually focusing on every part of gait. But with that standard walker, that doesn't exist because pick up, step, pick up, step, pick up, step. That's not a normalized gait pattern, right?
Okay.
So why is 4 point the most cognitive? Well, think about what you got to do for 4 point. Crutch, affected leg, crutch, bad leg. You've got to really think while you're doing it.
Yeah, left, right, crutch.
Yeah.
Crutch, left, yeah.
Okay, I just want to say that standard walker, I normalized, yeah, you were going the right path, but I think the assistive device threw you.
Yep.
Okay, what method are we using here, first of all?
What do you, what? Oh, Mackenzie.
Good.
I don't know swimming. I can barely swim. I get so angry when I get these questions. Okay.
There's two that you can rule out.
Doggy paddle, I guess.
Okay, good.
All right. Okay.
You can definitely rule out doggy paddling.
That's how I swim.
Okay, so I'm going to say that you can also rule out contraindicated. Why?
Because you can swim.
Okay, well, because you swim, but also think about the low back. What's going to happen when they're in the pool to those discs?
Oh, they kind of float more.
Yeah, so they're going to float more. You're going to take weight bearing off of them, so they're going to spread out.
Mm.
You're going to get a naturalized traction going on,
That's cool.
right? Okay, so swimming is actually ideal for low back patients. So then the question just becomes, and you don't have to know the how to swim here, okay? So don't totally freak out here. All you have to think of is which way I'm laying in the water.
Oh yeah, back. You're on your back.
Front, I'm on my front.
Front, you're on the front. Okay.
Right? Breaststroke, I'm on my front. Right? Backstroke, I'm on my back. I forget what the sideline one's called. Overhead stroke, I'm on my front again because I'm going that way. Right? That's what you typically see in the Olympic swimmers, right?
What does the front crawl look like? Do you know? Can you mimic it?
I think that's actually what I just did. I think that's the technical term for it, is that overhead swing, the overhead swimming.
Is that it? Okay.
Yeah, I think that's front crawl. I don't even know, to be 100% honest.
Yeah.
I just know that that's the right answer because what
Front.
direction am I going to when I do that?
Anterior.
Oh, well, not, well,
Or, no, I mean, flexion.
I'm going into extension.
Extension.
What?
Yeah, because I'm laying with my front on the water, which means my back has to be lifted up to keep my head out of the water. Think about it. If I lay on my back, right, I'm going to kind of be going extension. But the problem is in order to do the back stroke, I have to flex up to get those strokes out, right? And so I'm going to be going this way, which is going to do what to that posterior bulge?
Lift up the pressure.
Yeah, it's gonna make it worse, right? It's gonna keep pushing it that way. When I'm on my belly here, I almost have to keep at a 45-degree angle like this. Does that make sense, Erica?
Oh.
And so it doesn't matter really what I do with my arms at that point, because in order to keep my head out of the water, I almost have to keep in a constant extension.
Well, I
Now-
got that question right for the wrong reasons.
That's okay. Breaststroke would be the most ideal. Why? Because breaststroke, I'm going to go from neutral up into full extension, neutral up into full extension, neutral up into full extension. That would be the best option, right? That would be the most McKenzie method, if that makes sense.
Mm-hmm.
The main idea here is, I think you got the right answer. It's just, you're just trying to get the disc to move back to the middle, right? That's all you're doing.
Centralization.
Centralization. Yep. Oh, what just happened? Hello? Did I lose you guys?
No.
No.
No, it's still here.
What the heck just
I don't
happened to that question?
I don't know.
All right, first of all, I don't know what happened to that question. You guys didn't even get to answer it. What is I forgot to put a timer on that. That's what that is. Sorry, that was my bad. I don't know if can I go, I can't go back to it. I'll bring it back up at the end. It doesn't matter. Denervated muscle, what is the only way to stimulate the innervated muscle? What type of current? Direct. That's it.
That's what I was going to say.
Yeah, that's it. So direct current is literally putting a car battery to the muscle.
Oh.
That's the only way you're going to stimulate the innervated muscle. There is no other current that's going to do it. It doesn't matter if it's monophasic, biphasic, direct, whatever. Doesn't matter. Direct current, if you ever see one of a direct current machine, it looks like most of them are little yellow guns. They have this point that comes out, they have a pad on the end, and then they have a dispersive pad you put somewhere else, and you take that gun, you find the neuromuscular junction, and you squeeze the trigger, and it sends a direct current into that neuromuscular junction.
That's cool.
Yeah. So here's the deal with that question. No matter what do you get on that, if you get one that says de-innervated, look for direct. So D and D.
D&D.
I don't know why I did that. Yeah, I didn't even give you a chance to, why? That's weird. Maybe I clicked too fast. All right, I'm only going to click once here. Okay, I'm going to click again.
Oh, here we go.
I did actually forget to put a timer. I just saw that it has 0 timer. That's why you guys didn't get a chance to answer it. Answer faster, Jaira. Okay, so stance phase, my leg is in what primarily?
Extension.
Extension.
Okay, which would then be exactly what they have. Is that
Yep.
going to be hard?
Ah,
No, right? That's going to be fine, right? Now, swinging through is going to be difficult because now I'm using what of the hip?
flexion.
Flexion.
Flexors.
Good, right? And the other thing I could actually say is, here's my other way of answering this question.
Yeah, I just played which one of these is not like the others.
Yep, good, right? Because all of these say stance,
Yeah.
right? So technically they're all wrong. Okay, good. That which way one of these is not like the others is fine. Oh my God, why did I think my mouse is really sensitive? I got to adjust the sensitivity down. There we go. First of all, you have to know what ESRD is.
That's what I was gonna ask.
Erica Sims really
Does not like this. No.
Depressed.
Depressed.
Yeah.
Oh,
Oh, did it just click, Jara?
yeah, yeah.
Okay, anytime you see ES, what is ES meaning?
End stage.
End stage. Good. Doesn't matter if it's ES PD, ES HD, ES RD. ES means end stage, meaning the patient is doing what?
Dying.
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 Yep.
Right? Now, does it matter now that you know that what the answer for the other three answers?
Well, yeah.
Not really. The first answer is going to be your right answer there. Why?
Oh, sorry. I thought you meant, does it matter that they're end stage?
No, yes, it matters they're end stage,
I'm
right?
like, yeah.
But that's the only thing that really matters in this question.
Right, because they're dying, so they won't have much to give. Yeah.
Right. So lower intensity is going to be better. What's the RD?
Renal disease.
Renal disease. Yeah. So they're going into kidney failure. Yeah. So anytime you see ESRD, any ESRD, ESCPD or ESPD, end stage pulmonary disease, ESHD, end stage heart disease, stuff like that, just end stage, low intensity. You know, we still want them to work out, but what possibly could happen if we're doing higher or moderate intensity?
Progress. The,
Yeah. It can speed
They
up the
could
progression.
literally die.
They could literally die on you.
Literally,
Yeah.
yeah.
Especially maximal intensity. Yeah.
Oh,
You know, maximal intensity, we're talking like, you know, full VO2 work, right?
yeah, my grandma just got diagnosed with stage 4, and I hate that I got questions right because of like my real life experience with that, like with the GFR, and I was
Yeah.
like, I wish I could have learned this a different way.
Unfortunately, that's why that's why I learned a lot of my autoimmune disease. So
Yeah,
we learn by real life.
unfortunately.
Oh, come on.
Oh, Jaira, I always think of you when we do.
Yeah.
Yeah, Jaira was my partner during the cranial nerve stuff.
When I gave you smells that didn't actually smell like anything,
Oh
That's
yeah,
right.
the
lemon juice.
Yeah.
lemon juice and like the coffee.
Yeah.
Great.
Good. Cranial nerve
Nailed
1.
it. Yay.
Right. Those should be gimme questions for you. I just want to throw at least one gimme in there so
Thank
that
you.
Erica's not so depressed.
No, I'm super stoked that I can finally understand these capsular pattern things, or the glides, whatever.
Oh, another capsular pattern.
Oh no. Oh.
She's like, oh, okay, this is not that bad.
So is a glide the same as a mobe?
Yes.
Oh, that's another thing that was freaking me out, because I'm like, what's a glide?
So I'll explain the theory between those two in a second.
Okay. And then also, when would you use a cephalocautal? Wait, I think you gave that.
Cephalodecautal. Well, it
Yeah.
depends upon what I'm doing. Distraction usually is when I do cephalodecautal.
Oh, that's right. Okay. Did I-
All right, so 20, good. 25 degrees of knee flexion, right? All
The
right,
geniuses.
so yeah, extensions definitely out. That's the close back position. Flexion, 125 degrees flexion, really not getting even 90. But the main thing there is not extension. So if they can only get to 10 degrees of flexion, 10 degrees of flexion is better than extended, right? If they, whatever they're in is better than extension ideally, but 25 is open back. So for a glide versus a mob, so there are two theories to this. Number one, a glide is a continuous motion. So a glide would be like in and out, 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 where a mob is more of a in, slow, back, slow.
Oh, okay.
That's one theory on it. The other theory is in states like where I come from, glides were done by PTAs, mobilizations were done by PTs. Because they said that so we were able to do grade 1, 2, 3, and 4 glides. We just couldn't do grades 1, 2, 3, and 4 mobs. And what the difference was, we didn't assess our glides. So like if I was doing an inferior shoulder glide, I would put nothing about how the patient did with that. All I'm doing is just doing the activity that the PT has assigned to me. And what that says is because the PTA says that mobilizations require the continuous and constant observation and assessment of a physical therapist. So my state said, okay, well, and then we'll just take the assessment portion out of it and call them glides.
I love when they do that.
Yeah. Right. So there are two different types of terms, but glide and the mobs are the same. And then also, like, when do I do a cephalodecadal? Well, like, technically a superior to inferior mob is cephalodecadal. Right.
So when would you use that though? Like on what?
I mean, I guess I theoretically could use it if, let's see which ones, like I use cephalodecadal, or technically it's more proximal to distal or inferior, superior to inferior on the hands a lot. I mean, like, especially at the radial ulnar joint to get some separation. Shoulder, if you're talking shoulder, why would you do it? I mean, if you've got somebody that's got a slap lesion, superior labral, anterior to posterior, and it's tight, that could work there. Or they've had slap surgery where they've repaired it. So superior labrum, right up here, anterior to posterior.
Right.
When they go in and repair that, that's going to have scar tissue, right? So technically an inferior mob at that point, or cephalodecadal mob, is actually going to break up some of that scar tissue.
So inferior to superior, cephalodecadal, and proximal distal are all the same?
Well, I mean, I at the shoulder, I technically could call them that. I mean, proximal to distal shoulder mob would be more distraction at the shoulder, pulling the humeral head out, right? But I mean, like if I'm looking at the elbow, yeah, pretty much the same. Think about it. Cephalodecadal, I'm pulling away. Superior to inferior, pulling away.
Yeah.
Right? Distraction, pulling away.
Okay.
Yeah. So it just depends on the joint, kind of. And, Nevada's got lots of joints. I added a lot of capsular pattern questions on purpose.
Thank you.
This should be a gimme.
Every time you say that, I start to freak out.
Ow, that was a patellar tendon.
Oh, wait. Okay.
Okay, so stretching and strengthening we're still going to do, right? But remember, if it is a capsular pattern, we are going to mobilize it. Period. Right?
I was thinking about putting aquatic therapy just to mess
with me, right? So I can throw something at you. Now, all those other three actually are valid therapies, right? But again, in this case, the most appropriate answer is joint mobilization. Now, when I do a joint mobilization, am I going to stretch? If I do, which mobs? Which are my two stretching mobs?
Are we talking like
Flexion
grade?
extension.
The grades.
Oh, the grade.
Oh, 3 and 4.
3 and 4. Good. Right. Grades 1 and 2 are for what?
Pain.
Pain.
Nutrition.
Good. Yep. Right. Swelling, just kind of mobilize, get some general heat motion, right? That's mainly what grades 1s and 2 are. Heat motion, swelling, and pain. That's kind of like, I like to think of grade 1s and 2s as my passive range of motions. Right? Because passive range of motion is just a heat motion, help with swelling and pain. Right?
Yeah.
And then I think of my grades 3 and 4 as kind of my stretching techniques, because that's where I'm getting into and is it still going to relieve some pain? Sure. Right? Because we're still going to get, the stimulation of the pain receptors and stuff like that. But for the most part, that's the way I think of it. But yes, patient has a capsular pattern, joint mobilizations. Capsular pattern, joint mobilizations. But if we ask the APTA, we don't do those. Oh, and all of you are now going, what the hell is shortwave diathermy?
Oh gosh, come on. Would not.
Shortwave diathermy is what type of waves?
Big waves.
Okay, big waves. Good, but what type specific?
Monophasic.
Microwave.
Microwaves.
Oh, microwaves.
Yeah, right? It's microwave. So, good thing that none of you picked implanted devices, because if they have implanted devices, shortwave diathermy's out, right? We definitely don't want to cook the baby.
I know. I didn't read it right.
That's okay. I just had to pick on you a little bit. I knew that was you that picked that. I was like, you can't cook the baby. I mean, no, I'm not gonna. No, we're not gonna go there. I'm gonna keep moving on.
It's a recorded lecture. Mr.
It's a recorded lecture. That's why I stopped as soon as I said it. Now,
My bad.
that's okay. What if instead of saying a patient with zero cognitive mentation, it said a patient with impaired cognitive mentation? Is that a contraindication?
That's a precaution then.
It's a precaution. Yeah. Right.
I think of that now because of you, Mr. McKeever, because you said something like, well, patients in comas still need this stuff. So
yeah. Right. But if your patient's got 0 and is, they're on planet Mars, pretty much doing most modalities at that point is not a good idea. Right.
Oh, so I said that wrong.
No, you're thinking right. Because even a patient that is in a coma has mentation, they're going to react for the most part to stuff, as long as they're not like in the Glasgow 0. Right. They're going to react some way. So patient with, I'm just saying that most of the patients with 0 cognitive mentation, even if you put an ice pack on them, you're probably going to get smacked in the face with the ice pack. Right. They're like, weapon.
Yeah.
I am King Arthur. But a patient with strained shoulder, why is that one not a contraindication?
Because you could use it for that.
Yeah, that's an indication. Yeah. Good. All right. We only got one more. Come on. We can do this. We're almost done. I guess I should put most likely there. Only because I had somebody ask me about this, so I added this one.
That was a good one.
LBP is low back pain, right?
Yes.
Okay, just making sure.
Yep. I specifically put abbreviations to make it harder.
Yeah, it worked.
Yep. You made you think a little bit more, right?
Yeah.
Now, and you guys all guessed right.
Oh,
or
nice.
answered right. Okay. It is patient with lymphedema.
Answered right. Thank you, Mr. McKeever.
I corrected myself. Now, could the RTC also have it?
Yeah.
Yeah.
Yeah, but it would probably be an empty
It'd probably be empty before it's boggy. You're right. They're probably going to avoid you even getting to a boggy feel.
Yeah.
Like, nope, stop that. Nope, stop that. Right. But theoretically, at 1 week status post-op, they could be boggy because they could have a lot of swelling. Right. The TKR, if they have a boggy end feel at that point, surgeon screwed something up. Right. Because that means they've got so much swelling in there, and at 6 weeks, good Lord, they better go see their surgeon, because what's probably happening at that point.
Infection.
Right? Low back pain, I don't have enough information on that patient. Right? That one's just one of those you're like, well, low back, wait, what? Right?
Antalgic gait.
Antalgic gait, yeah.
Antalgic gait.
Exactly. Now, if it says something like a low back patient with, I don't know, a 500-pound low back patient, I mean, technically, they could theoretically have boggy. It's not true boggy at the point, it's more soft.
Yeah.
But I mean, if you've got a really massive patient, most of the time they're swollen anyway. So that could theoretically be boggy. But most of the time, boggy is lymphedema. All right, I made you all cry now.
Yay, thank you.
Okay,
This
that's
is a really good one.
so what I'm doing is when I post this, I'm also under the YouTube video. I don't know if you saw it on the last one, but under the YouTube video, when I posted it, I put the Slido link at the bottom of that in case you wanted to go back to the questions.
Oh, cool. Thank you.
So I have to keep, just if it ever is not there for you guys to view, just to let you know, I have to keep going. It only runs for a week, so I have to keep going back in and renewing it. Mainly because they just don't want people like keeping these open forever. I understand that, keep server load down, stuff like that, but I can keep adjusting them every week. That's not a big deal until you guys test anyway.
Okay.
How do you feel after that? A little knowledge gained?
Yeah.
Yeah.
Okay, good.
Feeling very good.
Sakana? Okay, good.
Yeah.
I mean, it's hard. Don't get me wrong. Right. And those were I intentionally picked some kind of hard questions people sent in order to give you guys a little bit of a learning experience. Was this more helpful than even doing the PowerPoints?
Oh, yes, 100% for me.
Yeah.
Okay, good.
Sure.
All right. Are there any questions I can answer between now and then? And yes, I don't know. When is then? Now, soon.
Tomorrow.
Trying to think
Be
about
okay?
it.
No, I think
Oh.
That fry you a little bit,
a little, yeah.
right? Need some food, need some breakfast. All right, guys. Well, if there's, again, keep sending me the questions you have. I appreciate it. Did that help answer those questions you sent to me, Erica?
A lot. Thank you so much.
See how I did that? I was thinking. If there are questions you're not getting, please let me know. Send me the questions. I may either answer them outright or I may save them. If you need additional appointments with me, please schedule. Like Kane and I have an appointment scheduled for next week. I have a couple with, I think, just scheduled. So if you guys need stuff, please schedule appointments with me. Texting is always the easiest. Like Erica texted me yesterday and I was able to get back to her pretty quick just because I always have my phone. I may not always be at my computer.
What if you don't have iCloud?
But you can still text me. I gave you my phone number.
Oh, did you? Okay.
Here,
Okay.
I'll type it into chat. That way you have it.
Okay, cool.
Yeah, you can still text me. It's fine. It's a lot of 7s.
A lot of 5s, a lot of 7s. It is, huh?
Yeah, it's I mean, it's one that I've always remembered. So, and I've had that one literally. So if you want to know how far, I've had that cell phone number since cell phones had cranks on the side of them.
Oh, Penn State. Okay.
Yep. Yes, Pennsylvania. Yep.
Huh.
So if you guys need anything, please contact me. I appreciate you guys, you three, showing up. I hope you guys, did all of you attend the meditation session or the test prep session or whatever that was called on Wednesday?
Yeah.
Yeah.
Did you guys like that?
No.
Yeah. It was
okay.
good.
It was okay. Yeah, well, that's what I kind of figured. I figured people that don't really have a lot of test anxiety are like, yeah, it was okay. But it seemed like the people that were test anxiety ridden really enjoyed it. Is what I kind of grasped from it when I was sitting at home, literally in tears from a migraine.
The better I feel about the exam, like the more my confidence goes up, the more my test anxiety goes down. But it was nice to just chill and relax for a little bit. And I think that's what I personally got out of it more.
Good. And also nothing against, but a lot of techniques you probably already used the martial arts. I'm just saying.
Yeah. I've actually rebranded it. I got this from that lesson. She mentioned something like, the state is just checking your knowledge. And in my head, I was like, yeah, this is just a knowledge check.
Mhm.
It's forget the word exam, forget the word boards or test. It's a knowledge check. Like
It's
I'm
a
trying to
knowledge and I'm going to add one other word to that. It's knowledge and safety check.
knowledge and safety check. Yeah. And I'm just keeping it more casual by saying that. And it's actually made me feel a lot better. Just,
Yep.
it's just
I like that
knowledge.
idea. It's
Yeah.
a knowledge and safety check. It's to see if you're going to be safe with patients.
Yeah. And that's it. That's,
Yep. All right, guys. I'm going to get going then. And I appreciate you guys attending. I'm going to stop recording. It's about 10:49. So we did about 2 hours.